Today's topic is meningitis. Meningitis can be classified into acute bacterial meningitis, acute viral meningitis, chronic meningitis. Acute bacterial meningitis caused by pneumococcus, meningococcus, Haemophilus influenzae, Listeria, Streptococcus agalactiae, gram-negative bacillus E. coli. Acute viral meningitis is mainly caused by enteroviruses, herpes viruses. Chronic meningitis is caused by bacterial agents such as Mycobacterium tuberculosis and fungal agents such as Cryptococcus. Coming to route of infection, heterogeneous spread, most common route enter into the subarachnoid space through the choroid plexus or through other blood vessels of the brain. Direct spread from an infected site present close to meninges causing otitis media, mastocytitis, sinusitis, etc. Anatomical defect in CNS result of surgery, trauma, congenital defect which can allow the organisms for ready and easy access to central nervous system. Direct internal spread along the nerve, least common route, occurs in rabies virus or herpes simplex virus infection. Coming to definition of meningitis, meningitis is an inflammation of the leptomeninges, arachnoid and pia mater surrounding the brain and spinal cord, the involvement of the subarachnoid space. It is caused by several pathogens including bacteria, viruses, fungi or parasites. Highest global burden is seen with bacterial meningitis. Acute meningitis is called as acute fulminant illness that progresses rapidly in a few hours, further grouped into acute bacterial or a pyogenic and acute viral meningitis. Chronic meningitis, it's progressively worsen over a week, more than 4 weeks, includes bacterial, parasitic, fungal, and viral agents. Some of the agents of chronic meningitis have a subacute course that progressively worsens over several days. Agent of chronic meningitis, bacterial agents includes Mycobacterium tuberculosis, Borrelia burgdorferi, Treponema pallidum. Borrelia burgdorferi cause Lyme's disease, Treponema pallidum causing secondary and tertiary syphilis. These are the rare bacterial agents which includes Nocardia, Actinomyces, Trophilema vipelli, Leptospira and Brucella. Viral agents or the agents of acute viral meningitis may also present as chronic meningitis, includes mumps, echoviruses, herpes viruses, human immunodeficiency viruses, and lymphocytic choriomeningitis virus. Parasitic agents includes Toxoplasma gondii, free-living amoebae, Trypanosoma brucei causing African sleeping sickness, Angiospermolus cantonensis causing eosinophilic meningitis, Lactostoma spinigerum, Bellus ascaris, rosinosis, cysticercosis, schistosomiasis, ichnococal disease, Toxocara canis, and Trichinella. Fungal agents includes Cryptococcus neoformans, Candida albicans, Blastomyces dermatitis, Histoplasma capsulatum, Toxoides immitis, Aspergillus species, Sporothrix shrinki, Pseudoescherichia boydii, and Cladophylophora pagiana. Chronic meningitis definition is the persistence of meningitis for more than 4 weeks associated with a persistent inflammatory response in cerebrospinal fluid, and the white blood cell count is more than 5 per microliter. Etiology includes infection caused by bacteria, viral, parasitic, or fungal. It accounts for a significant proportion of cases, may also be caused by non-infectious causes like malignancy, autoimmune disease, and chemical meningitis. Clinical forms, two clinical forms, chronic persistent meningitis, chronic recurrent meningitis, and CSF findings predominantly lymphocytic and elevated neutrophils are present. Aseptic meningitis, infectious etiology is unidentified. Aseptic meaning means its lack of infection. Includes agent other than the acute bacterial meningitis, such as the agents of acute viral meningitis and chronic meningitis. Patients with meningitis present with high-grade fever, vomiting, headache, neck rigidity, and certain signs like Koenigsegg-Brzezinski signs is positive. Acute bacterial meningitis is also called as pyogenic meningitis. is an acute purulent infection within the subarachnoid space. It is characterized by elevated polymorpho nuclear cells in cerebrospinal fluid. Agents implicated in pyogenic meningitis vary according to the age. Overall, Streptococcus pneumoniae is most common. Other agents include Meningococcus, Streptococcus agalactiae, Listeria, and Haemophilus influenzae. In neonates, Streptococcus agalactiae, Gram-negative bacilli, Escherichia coli, Klebsiella, Listeria monocytogenesis can cause acute bacterial meningitis. In elderly more than 60 years, Streptococcus agalactiae and Listeria monocytogenes can cause acute bacterial meningitis. So pathogenesis, it is transmitted from person to person through droplets of respiratory secretion from cases or nasopharyngeal carrier. Close and prolonged contact like kissing, sneezing, or coughing on someone with an infected person facilitate the spread of the disease. Route of infection can be transmitted by heterogeneous spread, direct spread from infected site, anatomical defect in central nervous system. Predisposing factors includes age. Neonates have the highest prevalence of meningitis. Widespread vaccinations shown to reduce the incidence of meningitis. Because respiratory tract is the primary portal of entry for many etiological agents of meningitis, it promotes the infection at the primary site. Presence of cerebrospinal fluid shunts and breach in the blood-brain barrier. Clinical features: the average incubation period is 4 days, ranges from 2 to 10 days. Fever, vomiting, intense headache, altered consciousness, and occasionally photophobia can occur. Signs of meningism, that is meningeal irritation, includes neck rigidity or nuchal rigidity, causing stiffness. Chronic sign is positive, and Brinsky sign is also positive. In laboratory diagnosis, the specimens to be collected is the cerebrospinal fluid is the most ideal specimen for pyogenic meningitis. Blood culture is another useful specimen for culture. Cerebrospinal fluid collection by through lumbar puncture under aseptic, strict aseptic condition. It is divided into 3 sterile containers, one each for cell count, biochemical analysis, and bacteriological examination. The CSF should be transferred immediately and should be examined immediately. When the bacteriological examination is required, CSF should never be refrigerated. If a delay is expected, it should be kept in incubator at 37 degrees Celsius. For molecular diagnosis, CSF can be kept inside the freezer. Cytological and biochemical analysis. In normal individual, the CSF pressure is normal. Total leukocyte count is 0 to 5. Predominant cell type is the lymphocytes. And the glucose is 40 to 70 milligram percentage. And total protein is about 15 to 45 milligram percentage. In pyogenic meningitis, CSF pressure is highly elevated and total leukocyte count is 100 to 10,000. Predominant cell type is neutrophil and glucose concentration is less than 40 milligram per deciliter. Total protein is more than 45 milligram per deciliter. In tuberculous meningitis, CSF pressure is moderate elevated. Total leukocyte count is 10 to 500. Predominant cell type is lymphocytes and glucose is slightly decreased. It is between 20 to 40 milligram per deciliter. And total protein is moderate to markedly increased. It is about 100 to 500 milligram per deciliter. In viral meningitis, CSF pressure is slightly elevated or normal. Total leukocyte count is about 25 to 500 and predominant cell type is lymphocytes. Glucose is normal and total protein is about 20 to 80 milligram per deciliter. It is normal or slightly elevated. Gram stain CSF microscopy shows gram-positive cocci in pair, capsulated, flame, or lanceolate shape. It is Streptococcus pneumoniae or gram-positive diplococci, flame, or lanceolate shape with clear halo. Nasal meningitis, appearance in CSF gram stream. It is gram-negative diplococci, capsulated with adjacent sites that is flattened, lens shape, or off-moon shape. Haemophilus influenzae CSF finding. It's pleomorphic gram-negative cocci bacilli. It's capsulated. E. coli It is gram-negative bacilli arranged singly. Streptococcus agalactiae, gram-positive cocci in short chains. Listeria monocytogenes, gram-positive short bacilli. So direct antigen reduction from CSF after centrifuge supernatant is discarded is used for antigen reduction. Latex agglutination test is performed using the latex beads coated with anti-capsid antibodies from the urine. It is useful for pneumococcal meningitis. Immunochromatographic test detects C polysaccharide antigen of Streptococcus pneumoniae in urine. Culture, ideal medium for bacteriological culture of CSF or enriched media like chocolate agar, McConkey, and differential media like McConkey agar. As the bacterial load is very low, a part of the CSF is inoculated into the enriched media. Red culture bottles at the bedside, it is preferable, or brain infusion brought in the laboratory. Red cultures can be collected in conventional red culture bottle, brain infusion broth or agar, or preferably in the automated red cultures bacterial. Culture plates, blood agar and chocolate agar are incubated at 37 degrees Celsius, preferably in a candle jar, providing 5% of carbon dioxide for 48 hours. Culture the identification of hygienic meningitis. In Streptococcus pneumoniae, the culture media shows alpha hemolytic colonies and red agar, described as Schwarzman shape or carom coin appearance. Biochemical shows biosolubility, ferments inulin and sensitive to opochin. Measles meningitis produce non-hemolytic colonies of red agar, which on smear shows gram-negative diplococci. Biochemical test, the catalase and oxidase positive. The ferment sugars like glucose and maltose but not sucrose. Doing serogrouping, slide agglutination serogrouping test is done to identify the serogroups of meningococcal isolates by using appropriate anti-sera. In Haemophilus influenzae, blood agar with staph aureus streaks lines shows satellitism. Biochemical disc test for X and V factor requirements shows growth surrounding a combined X and V disc. In Streptococcus agalactiae, media produces beta hemolytic colonies and red agar, which on smear shows gram-positive cocci in short chains. Biochemical shows CAM test positive and resistance to bezitracin. Serogrouping with group-specific anti-sera shows Lansfield group B. Gram-negative bacilli meningitis caused by E. coli and Klebsiella produce lactose-fermenting colonies in McConkey agar identified by indole, citrate, urease, and triple sugar ion test. Non-fermenta such as Pseudomonas is oxidase positive, whereas Acinetobacter is oxidase negative. They produce non-lactose fermenting colonies identified by indole, citrate, urease, and TSI test. In Listeria monocytogenes, it shows tumbling type of motility at 25 degrees Celsius, but non-motile at 37 degrees Celsius, called differential motility, which is due to temperature-dependent flagella expression. Blood agar shows beta hemolytic colonies, and it can be inoculated in the chocolate agar. Antimicrobial susceptibility test is done to initiate the definitive antimicrobial therapy. CSF blood culture takes more than 48 hours for identification. Sensitivity drops rapidly prior antimicrobial therapy or delay in processing. Rapid diagnostic test can be done by detecting the antigen or by doing molecular test considered to determine the bacterial etiology of pyogenic meningitis. Serological diagnosis, antibodies to capsid antigens of meningococci detected in patient serum by ELISA. It is useful to study the seroprevalence and to know the response to vaccination, not for diagnosis. Molecular methods, they are highly sensitive, detect even few bacteria in CSF with less turnaround time than the culture and also help in serogroup identification. Multiplex PCR and multiplex genetic PCR can also be done. Biofire film array can also be done. Common genes targeted in molecular methods includes for meningococcus, capsule transport gene and copper zinc superoxide dismutase gene. For pneumococcus, it is autolysin gene, pneumolysin gene, and pneumococcus surface antigen A gene. For Haemophilus influenzae, it is a conserved capsular gene detected. So treatment of pyogenic meningitis, the mortality of pyogenic meningitis is very high, and among these survivors, up to 50% developed complication. Treatment should be initiated as early as possible. The choice of antimicrobial agent based on the type of organism suspected and good CS of penetration ability of the agent. Empirical therapy consists of, in adult, IV cefotaxime or a ceftriaxone and vancomycin is given. If diphtheria is suspected, intravenous ampicillin is added to this regimen. For neonates, intravenous ampicillin plus gentamicin can be administered. IV dexamethasone is added to the regimen to reduce intracranial pressure. Definitive therapy, after the culture report is available, empirical therapy is modified based on the organism isolated and its antimicrobial sensitivity pattern. Viral meningitis definition, it is inflammation of subarachnoid space due to viral etiology. Second most common type of meningitis, often less severe and better prognosis next to acute bacterial meningitis. It is caused by enteroviruses. Most common cause and less common viral agents are herpes virus, arboviruses, lymphocytic meningitis virus, and other virus includes mumps, measles, influenza, human immunodeficiency virus. So people at risk are the children less than 5 years old and old age, immunocompromised individuals, chemotherapy or transplant recipient, transmission from close contacts with infected patient. In non-winter months, it is most common from late spring to fall. Common symptoms in children and adults includes fever, headache, infrontal or retroorbital region, neck stiffness milder than bacterial meningitis, photophobia can occur, sleepiness or trouble waking up from sleep, nausea, irritability, vomiting, and lack of appetite, and lethargy. CSF analysis is normal or slightly elevated protein level, normal glucose level, normal or mildly elevated cerebrospinal fluid pressure, and cell count. It is 25 to 500 microliter in some viral meningitis, like lymphocytic meningitis virus and mumps. The cell counts of several thousands per microliter may be seen. Lymphocytes predominant cell type, although neutrophils may predominate in the first 48 hours of illness in some viral meningitis. Example is West Nile virus. Organisms are not seen on gram stain of CSF. Molecular methods includes amplification of specific viral DNA or RNA from CSF by polymerase chain reaction, PCR of throat washing or stool specimen for enterovirus infection. Then multiplex PCR and multiplex real-time PCRs can also be done. Biofire film arrays are done. Viral culture, sensitivity of CSF culture, they are generally poor. In addition to CSF, specific viruses isolated from throat swab, stool, blood, and urine sample. Isolation of enteroviruses from the stool is not diagnostic. Primarily symptomatic cases, use of analgesics, antipyretics, antiemetics, and fluid and electrolyte replacement. Oral or IV acyclovir given for herpes simplex viruses 1 or 2 and severe Epstein-Barr virus infections or varicella zoster virus infection. Patient with HIV meningitis, highly active antiretroviral therapy can be administered. Enteroviruses, they are transmitted by fecal-oral route. They multiply in the intestine, do not cause any intestinal manifestation. They are associated with various systemic manifestations. They are divided into several, more than 115 human serotypes. Polioviruses cause myelitis. Coxsackie-viruses, ecoviruses, parvoviruses, enterovirus 71 cause aseptic meningitis. Other enteroviruses include enterovirus 68 cause pneumonia, enterovirus 70 causes acute hemorrhagic conjunctivitis, enterovirus 72 is reclassified as hepatitis A virus. Enterovirus 71 caused large epidemic of meningitis in Southeast Asia. Also, it caused encephalitis, hand, foot, mouth disease, angina, this similar to Coxsackie viruses, and paralysis resembling poliomyelitis. Herpes virus meningitis. A number of herpes viruses can cause meningitis. It includes herpes simplex viruses, varicella zoster virus, Epstein-Barr virus. Rare causes include cytomegalovirus, human herpes virus 6. Herpes simplex virus, second most common cause of viral meningitis next to enteroviruses. Adults are more commonly affected than children. Herpes simplex virus 2, more frequent cause of meningitis than herpes simplex virus 1. Arboviral meningitis. The encephalitic arboviruses sometimes cause meningitis, especially in individuals recently traveled to the areas where these viruses are endemic. They are transmitted by the bite of their arthropod vectors, causing West Nile viruses, St. Louis encephalitis viruses, tick-borne encephalitis, California encephalitis virus. Coming to HIV meningitis, meningitis and HIV infection may occur following primary infection in 5 to 10% of cases and is commonly at later stage of illness. Cranial nerve palsies occur involving the cranial nerves 5th, 7th, or 8th are more common in HIV meningitis than in other viral infection. Mumps meningitis cause perioditis. Meningitis in mumps, they are secondary to perioditis. It's more common in the late winter or early spring season, especially in unvaccinated children with male predominance. Lymphocytic meningitis virus affects people with history of contact with rodent droppings or urine. Some patients have an associated rashes, pulmonary infiltrates, alopecia, perioditis, orchitis, or myopericarditis. Bacterial tuberculosis infection of central nervous system. So tuberculosis in CNS accounts for 5% of extrapulmonary cases. It is seen most often in young children, but also develops in the adult infected with HIV. Presence in two clinical forms, tuberculous meningitis and tuberculoma. Tuberculous meningitis results from the heterogeneous spread of primary or post-primary pulmonary tuberculosis. Disease evolves over 1 to 2 weeks or longer in duration. Clinical features includes headache, slight mental changes, low-grade fever, malaise, night sweat, anorexia, and irritability. Evolve acutely with severe headache, confusion, lethargy, altered sensorium, and neck rigidity. Cranial nerve paralysis, ocular nerves in particularly affected, it's a frequent finding, and stroke due to involvement of cerebral arteritis. Ultimately, it progresses towards coma with hydrocephalus and intracranial hypertension. Coming to lab diagnosis, in CSF analysis, there is a high leukocyte count, mostly lymphocytic. Neutrophils elevated in the early stage. Protein content is about 100 to 800 milligram per deciliter, and glucose concentration is low. When CSF is kept in a tube for 12 hours, pyroglam forms in the form of cobweb, higher fibrin content in the fluid. Acid-fast staining of CSF, direct smear of CSF sediment shows long, slender, beaded acid-fast bacilli. Culture of CSF gold standard test. It's a time consuming. It takes 4 to 8 weeks by Lowenstein-Jensen medium and 2 to 3 weeks by automated liquid culture. It is mycobacteria growth indicator tube. Gene expert assays can be done by the automated real-time PCR, sensitivity of up to 80%. CT in the MRI shows hydrocephalus and the abnormal enhancement of basal systems. Treatment includes initiated immediately upon a positive gene expert results. Negative results does not explore diagnosis of tuberculosis and requires further diagnostic workup. Responds well to anti-tubercular therapy if it is started earlier. Then adjunctive glucocorticoids are used to reduce the CSF pressure, resulting in faster resolution of infection. Mucoborreliosis causing Lyme's disease is caused by Borrelia burgdorferi, is transmitted by tick bite. It causes cutaneous lesion, arthritis, and central nervous system infection. Clinical manifestation includes meningitis, encephalitic signs, cranial neuritis, includes bilateral facial palsies and radiculoneuropathy. CSF findings includes elevated lymphocytes, elevated protein levels, and normal or slightly low glucose level. Meningopolyneuritis, it is nothing but it is a radicular pain with CSF pyocytosis without meningeal or encephalitic signs called as Banworth syndrome. Resolves completely within a month but rarely A chronic neurological disease may occur later. Treatment includes intravenous ceftriaxone for 14 to 28 days. Alternatively, intravenous cefotaxime or intravenous penicillin G can be given. Neurosyphilis is caused by Treponema pallidum, causing tertiary forms of syphilis, whereas neurosyphilis develops in about 10% of untreated patients. It is sexually transmitted disease. Invasion of CNS occurs early within the first few weeks of infection, followed by years of asymptomatic period. Clinical manifestation includes asymptomatic neurosyphilis, meningeal syphilis, meningovascular syphilis, general paresis of insane, and tapes dorsalis. Laboratory findings: CSF analysis shows increased lymphocytes, increased protein level, and in CSF, medial test is performed. It is non-treponemal test detects antibodies against cardiolipin antigen derived from bovine heart. Fluorescent treponemal antibody absorption test can be done, and PCR-based tests can also be done. Treatment of neurosyphilis includes aqueous crystalline or procaine penicillin G is given for 10 to 14 days for neurosyphilis. Retreatment if non-treponemal titers in CS do not decrease by 4-folds within 2 years of completion of treatment. Patient with penicillin allergy, desensitization to penicillin has to be done, following which penicillin is administered. Thank you.